Hello people, this video is on ACE inhibitors and ARBs. These are some of the commonly used ACE inhibitors. You have captopril, enalapril, fosinopril, lisinopril and ramipril. You can also pause this video to make sure you just familiarize yourself with these names. And as you can notice, all these drugs have the suffix pril. All these drugs end with PRIL or pril. Right. And a fun fact about these drugs is that ACE inhibitors were for the first time found in the venom of Brazilian pit vipers. Okay. Now coming to the mechanism of action of these drugs. For understanding the mechanism of action of these drugs, we have to understand RAS or renin-angiotensin aldosterone system. Renin is an enzyme which is produced by the juxtaglomerular cells in the kidney, and this converts angiotensinogen to angiotensin 1. And angiotensin 1 is converted to angiotensin 2 by an enzyme called ACE, angiotensin converting enzyme. This enzyme, angiotensin converting enzyme, is present predominantly in the pulmonary vasculature. And so now we have angiotensin 2. So this angiotensin 2 will increase the aldosterone production from the adrenal gland. And this angiotensin 2 is also a powerful vasoconstrictor. So it will produce vasoconstriction and end up increasing the BP, and it will increase aldosterone production and increase sodium water retention in the kidneys and also increase the BP. So these are the two mechanisms by which the renin-angiotensin aldosterone system manages to increase the BP. Now what do these ACE inhibitors do? These ACE inhibitors act at this step. They go and inhibit this angiotensin converting enzyme. So I will never have angiotensin 2 itself. They block the pathway here. Okay. So this further pathway does not take place, and there will be decrease in BP. Right. This is the mechanism of action of angiotensin converting enzyme inhibitors. Now, let us talk about some of the therapeutic uses of ACE inhibitors. ACE inhibitors are one of the first line drugs used for the management of hypertension. Why are ACE inhibitors preferred? First of all, they are safe in diabetics and asthmatics. Right. Beta blockers, non-selective beta blockers cannot be used in asthmatics as well as in diabetics. So ACE inhibitors do not have this disadvantage. So we are using it. One more thing is thiazide diuretics tend to produce hyperuricemia, but ACE inhibitors do not produce hyperuricemia. And there is no dyslipidemia as well. So these are some of the reasons for which we are preferring ACE inhibitors as one of the first line drugs. Now, ACE inhibitors can also be used for the treatment of or the management of congestive cardiac failure because they prevent ventricular remodeling. Angiotensin 2 causes the growth of cardiomyocytes. They cause the growth of cardiac myocytes, and there will be increased demand for blood by the growing cardiac myocytes, but there won't be any vascular remodeling to cope up with the increasing demand of the growing cardiac myocytes. Because of this reasons, there will be myocyte death occurring, leading to heart failure. Right. So this process can be prevented because angiotensin 2 production is reduced by the administration of ACE inhibitors. So this is the rationale why we are using it for congestive cardiac failure. And one more reason is that they go and prevent peripheral vasoconstriction, which is caused by angiotensin 2. If the peripheral vasoconstriction produced by angiotensin 2 is blocked, then the afterload of the heart is also reduced. So that's beneficial for the heart. So congestive cardiac failure. So these are some of the reasons why we are preferring ACE inhibitors in congestive cardiac failure. The third use is in diabetic nephropathy. For some reason, ACE inhibitors slow down the progression of diabetic nephropathy. So they are used in people with diabetic nephropathy as well as other non-diabetic causes of nephropathy. Now, the fourth and final use of ACE inhibitors is that they are used in scleroderma crisis. In people with systemic sclerosis, otherwise known as scleroderma, there are several renal crises which can occur due to increased angiotensin 2 production. So, in people with scleroderma crisis, we can use ACE inhibitors. They provide some significant relief. Now, Coming to the adverse effects of AC inhibitors. The major adverse effect happens to be angioedema and dry cough. Angioedema is quite rare, but dry cough happens to be quite common in people who are using AC inhibitors. The dry brassy cough occurs in about 10% of the patients taking AC inhibitors. The reason is because this angiotensin converting enzyme is very important for the breakdown of substance P and bradykinin in the pulmonary vasculature. Okay, but this breakdown does not occur if I am blocking this enzyme by using ACE inhibitors. You get me? So, substance P and bradykinin will accumulate, producing cough and angioedema. Right, this is the mechanism why ACE inhibitors is producing cough and angioedema. Now, rashes, fever, alteration in taste, these are also possible, some of the possible adverse effects. And hyperkalemia is one of the important adverse effect. Right, why is hyperkalemia occurring? For it, again we go to the renin-angiotensin-aldosterone system, where aldosterone, increased levels of aldosterone will cause sodium and water retention and potassium excretion. The normal function of aldosterone is to produce sodium and water retention and potassium excretion. Right, and I am blocking this enzyme again. Here also I am blocking this enzyme by using AC inhibitors. So what am I to expect? There won't be potassium excretion. This potassium excretion won't take place. Therefore, potassium will accumulate, leading to hyperkalemia. Okay, so these are the common adverse effects, and we also have other two adverse effects. Increase in serum creatinine. Those people who are under therapy of AC inhibitors, therapy with AC inhibitors, there will be increase in serum creatinine levels. Up to 30% above the baseline value is acceptable. Okay, more than that maybe requires dose reduction. Now the final adverse effect is teratogenicity. So they are never to be used in pregnant women because they can cause fetal malformation. And these are some of the contraindications for the use of AC inhibitors. Of course, they cannot be used in pregnancy, just now we saw. And in bilateral as well as unilateral renal artery stenosis, we are not supposed to use AC inhibitors. And for people with known hypersensitivity reactions to this drug, we are not supposed to use AC inhibitors. And also in people with renal failure, dose reduction may be required. Now coming to angiotensin receptor blockers or ARBs. Okay, we have these drugs which are some of the commonly used drugs: candesartan, valsartan, telmisartan and irbesartan. So as you can observe here, all these drugs have a common suffix sartan, S-A-R-T-A-N. Right. Now coming to the mechanism of action of ARBs, they also act in the same system. Renin-angiotensin-aldosterone system is affected here as well. And AC inhibitors block this step, this conversion of angiotensin 1 to angiotensin 2. But angiotensin receptor blockers do not block the conversion. Rather, they go and block the receptors for angiotensin. Okay, so that the action of angiotensin 2 cannot occur. The block occurs at this step. So ultimately, the mechanism of action happens to be somewhat similar for both AC inhibitors and ARBs. They block peripheral vasoconstriction and they also make sure that this increase in aldosterone levels does not occur. And therefore, there is decrease in BP. Okay. Now, ARBs are similar to AC inhibitors in many ways. Yes. And ARBs cannot be used in scleroderma crisis. This might be one of the differences between them. And the main important difference between AC inhibitors and ARB inhibitors and ARBs is that the incidence of cough and angioedema is much lesser with ARBs. So the incidence of cough and angioedema is much lesser with ARBs than with AC inhibitors. So this is the common difference. This is the most important difference between these two classes of drugs. And that's it.